right, ladies and gentlemen, we're going to start slowly. The number of participants is still going up. We have like almost 230 now, which makes this, I'm sure, one of the best attended grand rounds ever. And there's a very good reason for that, because these are very special times and we all need to cope with that. The patients, their families, and of course the healthcare workers, and especially those on the front lines and the people helping those. And that's exactly what this grand round is going to be on how to cope with these disasters. And fortunately, we have one of our own, Dr. Greg Katz, who is an expert in this field, because he founded and directs currently the program Global Mental Health. And in fact, that came because he had an interest and was affected by natural and other disasters. One of them, the 9/11 disaster, which also hit New York, of course, quite severely. And he has been directing the World Trade Center Mental Health Screening and Treatment Program for the first responders for the 9/11 program. So he's an expert in the field of how to cope with man-made and other disasters. Dr. Katz attended Harvard College and then went to Columbia University, where he obtained his medical degree and completed his residency's training in psychiatry and served there as chief resident. He then did a fellowship in forensic psychiatry at NYU. He has been, as I said, very active in the field of working in disasters and from a psychiatric perspective. He is a distinguished fellow of the APA, and he is also a consultant on the National Board for PTSD, and interestingly, the International Association of Firefighters. So he's an absolute expert, and I'm very glad that he's here and going to present. And then just to give you a little bit of perspective, we have 325 registers now, which Greg is making this, I'm sure, the best attended grand rounds. And I'm very glad you're here to do this. You volunteered to do this several weeks ago, when you must have felt this was going to be a disaster, and hopefully we can cope with that. But you're going to tell us what the consequences are. And obviously, this is on the mind of many, many of us. Thank you very much for doing this. You're going to present for about 45, 50 minutes, and then we have another 10 minutes for questions, and you can ask them, the audience, by using the question and answer button and the lower end of your screen. So Greg, thank you very much for taking this initiative and for helping us out, for sharing your enormously important expertise. Thank you very much.
Okay. Thank you, Dr. Kahn, and thank you, everybody. I'm going to share my screen now. Thank you, everybody, for joining us today. I really hope, I know everyone has got so much going on and so much on our minds. So I really hope that you find this worth your time. And for a little bit of perspective, I was on 9/11 itself, which was on a Tuesday, on a Grand Rounds day. Grand Rounds were sort of hastily reconfigured, and I gave a talk that day. And I say that just a little bit of perspective that, we got through that. I think that I'm hoping we'll get through this. But what I'm actually going to talk about today is a lot of history. A lot of history. So I'm going to, these are the objectives. I'm basically going to share with you a lot of background on common human reactions to infectious outbreaks in particular, and talk about the factors that influence how people react, and then hopefully get you to think about how these largely historic lessons could be applied to your own practice in whatever field you're in. So this is the outline. We're going to go all the way back to the Black Plague, and all the way actually up to COVID-19, because there is some data that somehow has actually already gotten published on mental health issues around COVID-19 from China. And then wrap up with some conclusions, some takeaways. Just one disclosure, Dr. Khan already mentioned this. I'm a trauma consultant to a facility that treats traumatized firefighters down in the DC area. Okay, so starting with the Black Plague. So this is way back in the mid-1300s. It struck in particular countries like Italy and England, a host of different manifestations, bubonic, pneumonic, septicemic plague. It was spread by respiratory droplets and fleas. And you could see just the incredible devastation that it wrought in Europe in particular. And it was an event that was, of course, plagued by an absence of any medical science or ideas, about hygiene and sanitation. And what you saw in human behavior at the time was social isolation and avoidance from one's community, which may sound familiar right now, but I'll show you on the next slide why I don't think it's quite the same. Fear and avoidance of the sick, yes, we understand that too. Flight out of one's country. I guess they were seeing people maybe fleeing for the countryside, but that's about it. Revelry and lawlessness, which thankfully I don't think we've seen. But here's a quote. Let me see if I can move this over so I can see it. Yeah, so this is a quote. So this is, to the extent that these are historically accurate, and I don't know otherwise, you could see that not only were citizens avoiding one another, but in this quote, you could see that families were as well. So that the Black Plague really created a level of social disruption that went to the very core of families and not just society at large. And so that is at a level of disarray that thankfully, to the most part, I don't think we're seeing right now, at least on any mass scale. So there was incredible economic disruption in culture. And what happened, right, it's often the case that from bad things come good things at some point. It's a little hard to see that right now where we're at in this pandemic, but usually positives come out at some point. And what the Black Plague actually did was empowered the lower classes and the serfs that were otherwise under the thumb of rulers. And also actually led to an increasing appreciation of public health approaches and authorities. So it may well be, one of the earliest beginnings of having public health systems. So that was some good that came from it. Fast forwarding quite a few years to what you've probably often heard about lately and maybe read about is the so-called Spanish flu pandemic in the early 1900s. So this, one of the greatest natural disasters in history, right? Over 50 million people died, like almost maybe a 20th of the world's populations. It's not clear what lessons I think can be drawn epidemiologically from it, but we can look at the government response to it. And President Wilson, that was the president at the time, he apparently made the decision not to talk about it, even as it was spreading. And public health officials at that point existed, where we had that system in place or some kind of system, but public health officials were found to either minimize or underestimate the risk or to actually overstate their knowledge and provide false assurances. Newspapers tended to either be silent or provide false reassurance. And this was the position of the Chicago director of public health, who didn't want to mess with the morale of the community, right? It is our job to keep people from fear. Worry kills more than the disease. And so they were taking the position of, just keep it quiet or only say something good if you're going to say anything positive. And what happened was what has been described as sort of societal drift. It was, and to some degree, I can't compare it item for item, but much like the Black Plague in terms of, incredible social disarray. Lots of rumors, people fear eating together and kissing together. Maybe that's not unreasonable, but the sick going uncared for, food not being delivered, and generally the finding that cities that were more direct about the risk and the precautions did better, right? So the beginning of what we increasingly know and appreciate and practice, that information and openness goes a long way. the healthcare system nearly collapsed, and that was partly also a residue from World War I. And there was huge absenteeism from places like shipyards. The rail system was paralyzed, including freight deliveries, and telephone system was put to task, and I forget why. Stores weren't opening, and this is on their own. This was, they weren't being told don't open the way we are finding here in New York right now and around the country, right? So a lot was left to the individual to decide. Almost everything actually was left to the individual to decide, except in some cities where there was more precautions taken. And this is a shot of the Seattle police in 1918. And just to give us some context, right, this is right 100 years ago. And, I guess right now the uniforms look different, the streets look different, but we're kind of looking the same. But hopefully we're doing things differently. And here too is a quote about the level of disarray that arose. Fear, this is from Philadelphia, right? Fear of breaking down trust, and referring to it as a general calamity, not just the outbreak itself, but in terms of how people were behaving with respect to one another. So from this, the idea of social distancing is thought to have gotten currency. And the idea that that ultimately was the most effective way to stem the outbreak. People also got an increasing appreciation that early public health measures make a big difference, and that truth-telling by the government is essential to reducing panic. Again, there were some cities that practiced that more than others, and it seemed to work in terms of getting people less panicky. So now we jump ahead to the late 1990s, not that long ago, and the pneumonic plague in India. So here too, we have just another example of just mass disarray. And in this case, particularly, I think it was the plague broke out in 8 different states in India. And in particular, what was documented is the disarray that occurred in the city of Surat, where hundreds of thousands of people fled, including doctors. Countries cut off India. There was medication hoarding, that certainly sounds familiar, and a lot of so-called psychological casualties, people coming into the hospitals with non-specific symptoms. And of course, there was enormous economic impact across India. And this is a picture of people trying to storm a train to get out of Surat in 1994. So the lessons learned, it's going to be a repeated lesson, right, is be transparent, right? Again, this was another case where the lessons from the Spanish flu really were not applied cross-culturally, I guess you'd say, or cross-continentally in India. And it led to just panic at an increased, at a remarkable level. So now jumping ahead, something that maybe we have a little bit more familiarity with, we've certainly been hearing more about lately, and that's SARS. All right, so SARS emerged in China in late 2002, followed by heading into Hong Kong in March of that, a few months later. The outbreak in Hong Kong started with hospital staff, moved into the community, peaked by April, and then declined. So, and it never, thankfully, really became a worldwide issue like we're dealing with now. There were all sorts of panic reactions in China. People were killing their pets due to some belief that pets were the source or contributing, at least to the perpetuation of it. There were lots of turning to alternative remedies, things like turnips and spicy food and other herbal remedies. Schools here in the States barred students from the Far East from coming, although they didn't bar them from Canada, although Canada did have, I think, an outbreak in Toronto. So there were some, differences in how other countries were treated. And, people began, on their own, trying to protect themselves and getting face masks and disinfectants. And, you see long lines, supplies being exhausted. That sounds familiar. There were rumors, rumors abound in these situations. This concern that apparently it's a rumor that Hong Kong was about to be sealed off was posted by a 14-year-old boy. It started with that and then just went viral, so to speak. Stores and supermarkets are mobbed until the government steps in and offers public reassurances. There's lots of hoaxes, fake face masks and snake oil solutions. And at the time, wine vinegar was thought to be a remedy, so that flew off the shelves. So people started isolating themselves, again, I think without government direction, and that's why this slide is labeled societal disruption. School children are kept home. Shopping and dining drop again, and I emphasize this, as far as I understand, was not done systematically, right? This is people taking their own initiative. And commercial areas are curtailed, and I think eventually the government caught up and actually started doing this in a more formal way, but again, it was really more of a, I guess we call it grassroots effort. So you see all this stuff online about avoiding going to China, Hong Kong, and then there's some studies. So this is a study of SARS patients at and it was just from one Hong Kong hospital, but they looked at PTSD and major depression, and you could see 30 months later, right? So that's about 2.5 years later, the rates of PTSD and major depression, the PTSD in particular, these are point prevalences, so these are actually enormously high numbers. And then the cumulative rate over the prior 30 months, almost half of these patients. Now, again, this is a very small sample, but it's very telling. Another study looked at the use of precautions. The government, this is in Singapore, the government in Singapore started issuing guidance for people what to do. The phone study looked at were there any factors that led people to listen to the precautions? So being a woman, being over 35, being anxious, and believing that the authorities, trusting the authorities, all led people to take precautions. Maybe some of those are not surprising, right? Anxious people looking for direction and getting it were more likely to use precautions. Now, healthcare workers are particularly on our minds right now, and our frontline workers, as we think of them, and maybe some of you maybe have the time to be on this call. So this took a look at respiratory staff 1 year later after the outbreak in Hong Kong, and you saw elevated rates of these are two different studies, I'm sorry. So the first study looked at respiratory staff, and they had elevated rates of post-traumatic symptoms, depression, anxiety compared to other hospital staff. I don't have the numbers here on that, but respiratory staff, being potentially at the core of the response. Singapore hospital staff in a different study, 2 months after the first SARS case, you see 20% with PTSD and 27% with caseness, based on something called the General Health Questionnaire, which looks at somatic, anxious, depressive symptoms. And people amongst the hospital staff, there was decreased risk of developing these problems if they felt supported by their supervisor or colleagues, or they felt that they had clear information about the precautions to be taken. And this is just a kind of a general overall slide on the psychological responses to SARS, right? Patient reactions, isolation, loneliness, stigma, getting really anxious around fever spikes, feeling fear and guilt about the well-being of their family, and insomnia, not surprisingly. Staff reactions, and I think certainly a lot of people are experiencing this. I know I'm experiencing this right now, conflict between duties and worries about exposing their family, and and trying to think about how to help and care for other healthcare workers potentially as they get sick. So lessons learned from SARS, you need a government CDC-like agency for coordination and communication. Where that was present, people did better. There was definitely a need for more mental health counseling. And ideally, you have a more responsible media to the extent that one can tell the media what to do. Now, the avian flu, this is a very brief section, although it was actually the avian flu outbreak in 2009 when I actually originally developed an earlier version of this talk. This too did not become anything approaching a pandemic, thankfully. And actually, many this was a case where people that did write about it, not that many people, I have to say, wrote about H1N1 from a behavioral perspective in retrospect. But the people thought, in retrospect, right, that the risk had been overstated, and that this was done by by the media, by experts seeking funding, by the pharmaceutical industry. That that there was sort of nefarious reasons why the pandemic, the risk of a pandemic was overstated, so that they described what they called an iatrogenic pandemic of panic, and commented that really we should be thinking about real health problems. Of course, the problem we see with this now is that understatement is a problem in its own right, and maybe it's hard to know what's understatement or overstatement until you're in the thick of the soup. Now, moving to the Ebola virus disease, which struck West Africa, and I think currently there's an outcropping of a few more cases there, but just a few years back. So the only studies that I was able to find on this, and we do some work in Liberia, so we have some sort of personal sense of the impact, but in terms of things that have been published, this is material that was published actually about promoting community in Liberia. What aided a sense of community during the outbreak and promoted the strength of the social fabric? Strong leadership, pre-existing tight bonds at the community level, which one doesn't have any control of at the time, but hopefully they exist. And we've seen this in other disasters, more cohesive communities. It's not surprising, but this was also found after Hurricane Sandy in the Gulf states. More cohesive communities, people do better. And actually lower rates of depression, for example. Of course, the question is, how do you make a community cohesive? And if the outbreak is already happening, then you have to take the community as it is. But in any case, trusted communication channels, the health system providers actually working together well and having trust amongst them makes a big difference, made a big difference in Liberia. And in this particular case, the extent that aid was flowing in, and this is probably always the case, things go better when the aid is dispersed in consultation with local people and not just sort of dispersed by people far above. So that was something about the cohesiveness of the community during the event. After the event, there was also a concern about how do you restore community cohesion. And Liberia is a somewhat unique example because it had gone through many years of devastating civil war and is still climbing out of it. So Ebola was an example of something, kind of hitting someone when they're down, or actually just as they were getting up. And so, community cohesion was such a big issue after the Civil War between different ethnic groups and people who are on different sides. There were so many different sides, it's hard to keep track of. So they were especially concerned about community cohesion. And what they did is establish what they called social reconnection groups. These, I think, were facilitated groups where they would get community members together when there was no longer an infectious outbreak. And they would do a few things. One is just basically deliver accurate information about Ebola. Whatever people weren't able to understand in the grip of the event, to help them understand it now and help them understand the risks that were posed, that may be posed to them, and maybe what precautions they could take going forward. It was also an attempt just to convey empathy to the communities and acknowledge and empathize with people's reactions to the stress. Help these groups are supposed to promote mourning since there was such a great loss. And also, interpersonal learning about one another, to the extent that there was the issue of stigma between people who had Ebola virus disease and who didn't, or who had family members that did, to try to break down whatever misinformation was perpetuating that. And this was I think a qualitative study. Nothing that's ever going to like a small qualitative study. Nothing that's ever going to make its way into something like JAMA. But I think intuitively these things make sense, and they've found in practice that these things make sense. So this, we'll see where all this takes us in our pandemic, but it's certainly something to be thinking about, particularly for the hardest hit communities. So that brings us to COVID-19. And somehow some people have managed to already publish data on mental health issues out of China on COVID-19. I was able to find 2 studies, at least, on it. So this first study was an online study of the general population, and they used a snowballing method. And as far as I understand, what they basically did is they created a survey, and they emailed it out, and they let people forward it, right? So it was just sent around the way things get sent around on email or social media these days. So it definitely was not in any way a systematically done study. They administered the impact of event scale, which is a proxy for post-traumatic stress disorder or post-traumatic stress disorder symptoms. And the scale I've never heard of, the depression, anxiety, and stress scale. So they got about 1,000+ respondents from 194 cities. So it's really, if you think about it, not very many per city at all. Somewhat more women, mostly people in their 20s, and majority married. So this study, I don't know if really what one can make of it, because you could see that the number of people that had contact with someone with suspected COVID was pretty low, and with someone with confirmed COVID even lower. And the study, as best as I can tell, didn't ask if they themselves had COVID-19 or had recovered from it. So what they found is that on the impact of event scale, the IES, over half reported moderate to severe psychological impact. On the other hand, on the depression and anxiety and stress scale that they used, depending on how you read this, but maybe 60–70% had actually normal scores, and the COVID-19 contact didn't correlate. So I don't know how much one can to make of the study methodologically, et cetera. One is, in terms of who's responding, et cetera. One is certainly more inclined to believe the impact of event scale, more than half of people having moderate to severe psychological impact. But that's one study nonetheless. And then this is a much more rigorously done study, and one that's, I think, going to be more germane to us here at Mount Sinai in our system. I took one in a hospital setting, a healthcare setting right now, and this was a study that randomly selected departments in 20 hospitals within Wuhan, right? And 7 hospitals in the broader Hubei province, and then 7 hospitals in other provinces with high incidence of COVID-19. And this was done in very, very late January, early February, around the peak of the cases. I believe that's around the peak in China. And they administered the PHQ-9 for depression, the GAD-7 for anxiety, again, the impact event scale, and they also looked at insomnia. And you can see it was about almost 40% physicians and 60% nurses. So it's not, I couldn't quite tell what they were using for their cutoffs in the paper. Maybe I just read it too quickly, but they said that the prevalence of depressive symptoms, and I'm not sure outright major depression or not, but half, high numbers for anxiety, a third for insomnia, very high numbers for distress, maybe not a surprise. And those who were at greatest risk were people from Wuhan, people on the front line. So were people that basically were at the so-called, right, what we might call the ground zero of this pandemic at the time, and women and nurses. And in a lot of trauma studies, women often tend to have more manifestations, and it's debated why that is, but that comes out here, and nurses, which seem to be separate, I believe separate from the issue of being a frontline worker, right? So this, definitely, I don't think we need a study to tell us this. I think we're all worried about everyone on the front line, nurses, et cetera, doctors, respiratory staff, but certainly this study is certainly a suggestion that we need to be worrying not just about, right now we need to be worrying about their physical health, but we also need to be thinking preventatively, and thinking ahead of the curve in terms of their risks down the road for developing, the kinds of problems that can wind up in our office one day, like PTSD and major depression. So some general observations now. That's sort of my historical review and review of the literature as I understand it. Right. So to take a kind of a step back, right? So there are 2 dimensions to an epidemic, or let's say a pandemic. One is the so-called biodemographic burden, right? That's the death, disease. And then there's a psychological impact. And probably you can think about it as a psychosocial impact, really. And that's why I think I have psychosocial in the title of this talk, right? Because we see the great social disruption, the economic disruption that can result as well. but let's just break it down into basically physical and psychological impact, or health and mental health impacts. So this is some information that's been written about. This is information that was back from the immediate post 9/11 era, when we were worried about weapons of mass destruction, and we were thinking about nuclear, biological, and chemical. And this is what was written about biological agents. And you could see this was not written about coronavirus, but you could see all of this completely applies to the elements of the coronavirus, the experience of it, the psychological experience of it. It's invisible. Where is it? It's new. There is no sight to the event. We have a sense that there are places where there are, of course, spikes in outbreaks and overwhelmed hospitals that we all know, or cities. We know all this too well, but there's really no real sight, right? And there's a sort of sense of this may be overstating it, sort of powerful but evil, imperceptible force, right? And then there's the effects of quarantine and isolation. We certainly hear about that and experience that a lot now. Other issues that came up that are thought to be an issue with biological agents that and again, I think applies so well to this situation, even though this is not a weapon of mass destruction. How to distinguish stress reactions from physical illness, and having non-specific presentations, and how many of us, and I will raise my hand here, right now had a cough or this or that, and you wonder, is it the start? There are potential concerns about psychiatric effects of treatment or non-treatment, and some of this has been discussed recently in terms of different remedies that are being tried for COVID-19, although I think that those are minimal concerns right now, given the need to come up with treatments. Delays in detection are a problem with biological agents because there's no announcement that it's happened. And then there's fear level of healthcare providers, right? So all these things from the world of terrorism actually apply to something that's going on right now that is not terrorism, but is certainly striking terror into our hearts. Right, so reactions to epidemic, as to kind of summarize some of the points from earlier, right? There's fear and flight. There's a lot of blame and explanation needed. There's an appeal to authority, civil or religious. I think we've heard from some religious leaders at the micro level and even at the global level at this point. There is a concern about the effects of an infectious outbreak on decision making. I think this is the case in any disaster, like how do leaders make decisions, people in positions of authority. But right, there's going to be a mix of decisions based on mortality and morbidity as well as fear. That's the reality. Fear creates a sort of pressurized planning environment. On the other hand, fear mobilizes resources and it enhances compliance. And I think there's the idea of the public as rational helpers in disasters. Right, that there, we've seen from historic examples, right, going back right to Surat in 1994, or the States back in the Spanish flu or the Black Plague, right, that there can be a major impact on social order. On the other hand, with the right number of ingredients, there is lots of evidence for cooperation, adaptation, and resourcefulness. And I think we're certainly living through this now here. And this sort of taps into, I think, I'd like to think, and I'll get to another slide that questions this, but our deeply ingrained norms of civility and sociality, that we are inherently social creatures. And so that in epidemics, you see it generally in later times, more so than not, you see initial social disruption lessening as response strategies and communication improves. And it's also important, of course, to think of the general public as not a monolith, right? But there are different pockets, right? So in our circumstances right now, or certainly frontline health care workers are in one group. People that are imprisoned or immigrants that are in detention are different groups facing risk, right? The different issues that come up for them. Well, this is a slide from SAMHSA that defines social distancing, quarantine, and isolation. I think we all, at this point have a pretty good sense of what these are all about. And, you know, probably like a month ago, we weren't thinking too much about these at all. But again, right, quarantine properly used is to restrict somebody who's been exposed, right, to prevent the development and spread of a contagious disease. Isolation is to prevent the spread of someone who's sick, right? And social distancing is the most preventative of all. According to SAMHSA, these are typical responses to social distancing. Probably, again, we're all living this. So in some sense, this slide may strike you as, may make you say, no, duh, but this is what we know about the different, all sorts of reactions that people have to social distancing. And you see a lot of this right now, although hopefully not the desire to use alcohol or drugs or symptoms of depression, but these are the things that we need to watch for. The experience of quarantine, there's a very nice study that came out, I think in JAMA a few weeks ago, that did a nice review of the experience of quarantine and what factors affected people's experience. So these are the factors. Of course, the longer in quarantine, the harder it is, not surprising. Not having supplies of whatever, health, food, etc. Fear of infection, and what they were talking about is, being quarantined and being concerned about infecting others. If you're, let's say, quarantining with the family, how do you do that? And lack of information. Now, lack of information these days probably is less of a problem. It's probably a problem with too much information and trying to sort it out. And so lack or confusing or overwhelming information maybe is better. And then, of course, whether the quarantine was voluntary or mandatory, and what it's like if a healthcare worker is actually helping people in quarantine, what it's like for the healthcare worker to be ministering to them, or isolation in particular. And then psychological issues that come up in quarantine, and this is from a study a long time ago, paper, right? Sense of dependence, effect on your self-esteem, feeling imprisoned, feeling unpopular or feared as a patient. Again, this would apply to quarantine or isolation. I'm using quarantine kind of loosely. Neglect, and then frustration and boredom, and probably boredom can't be overstated as a problem. And then there are psychological issues post-quarantine, financial stress, which hopefully some government or corporate actions will help remedy, and then stigma of being the person who was, particularly if one was isolated, and how people approach you. And I don't know how much of a factor that's going to be in different places here in the States, in different communities and different almost cultures within the States, but we can imagine that being a problem. This is just a great quote that a friend of mine, former Mount Sinai resident, sent to me. It's just, I share it just as it's nothing scientific here, just a nice quote to remind us that social distancing is not mutual distancing, and thankfully we have phones and the internet to stay in touch. And it's I think it's hard to feel lucky right now, and many people are probably feeling very unlucky, to say the least. But we're lucky to have the internet to even be able to do this, so that our social distancing is physical only and not emotional, not psychological. Okay, to bring this into some conclusions, right? So historically, you see repeated social disruption during public health emergencies, but then with the potential to evolve into order and cooperation. Fear is actually essential in any epidemic and pandemic, and I'll speak to that more in, I think, a slide or two. But basically, right, anxiety and fear motivate. We know the crucial role of information and credible communication in shaping public reaction and human behavior, and trying to strike a balance between complacency and panic, right? That's the sweet spot that we're searching for. I don't know. I imagine most of us on this call are mental health professionals of some sort, but either way, when you look back at the historical record about outbreaks, you actually don't see, I haven't been able to find much of anything about the role of psychiatry, mental health professionals. So I would sort of say that this time, I think can be different. I certainly know our department is mobilizing to to help our fellow healthcare workers and the community. So hopefully we're going to be writing some of the script in a very powerful and impactful one. Anyway, leadership and decision-making appears to be essential. The long-term concerns, right? These are the big two, or really potentially three, but post-traumatic stress disorder, major depression, and recurrent alcohol use problems. I didn't mention alcohol simply because it hasn't been studied in the infectious literature, disease literature that I found. But in general, from disasters, that's the big three, or trauma, PTSD, major depression, and alcohol use disorders. And these are things that we need to kind of be thinking ahead to, particularly in the highest exposed, highest risk populations, which you would think, right, would be our fellow healthcare workers and the aggrieved, the bereaved. And it's important to think about, again, the idea that there's positive outcomes come from these things. This may sometimes take time to figure them out. There's, of course, immunity, we hope, immunologically. Social change, like I mentioned earlier, empowerment of the serfs, I certainly wonder what effect this might have. I'd like to think that some good might come of it for our immigration system, but it's hard to imagine what that is right now. And improve governance, that would be a nice thing. That's always a good thing. This slide, I probably should have had a slide earlier, but you all may be familiar with this. I find this in general one of the most useful concepts even in normal times, and certainly in abnormal times, right? But this is the idea of anxiety or stress and how it affects our performance, and gets back to the idea that we need some anxiety or stress to perform. And this, even goes back to like one-cell creatures who, look like they're stressed if you put a noxious stimuli to them, and their flagella, go all over the place, and hopefully they move in a systematic way and move them away from the noxious stimulus. So what we are aspiring to is optimal stress, right? That sweet spot right in the middle between complacency and panic, where we want to keep ourselves and our family, friends, and our patients on the good side of stress and not on the bad side of stress. And really, what this curve doesn't do, it really should dip below the x-axis into negatives on the y-axis, because bad stress obviously can not get you down to zero performance, but dysfunctional performance. So I really like to keep this in mind. I like to talk with people about this a lot, because I don't want people to be afraid of the fact that they are afraid. We should be afraid right now. We just like to kind of try and define the right level of afraid. And we don't want people to feel embarrassed that they're afraid, or feel that they have to cover it up. And because we also want them to act on it and do the right thing, and socially distance and wash their hands, etc. So just some limitations before I wrap up. The information I provided here that I've collected, aside from some of the medical journals I've cited, is largely narrative. So we don't know its full accuracy. Historical accounts, just like we find even in social media, are probably biased towards the extreme. We don't know really the exact proportion of panic to normal behavior in the past, but it does seem that there was a proneness to panic early on, and sometimes indefinitely, depending upon the event and the time frame and the era. We believe lack of transparency in public communications is a source of panic and problems, and even at the level of staff-to-staff communication in the hospital. I mean, technically, no one's done a double-blind, placebo-controlled, or whatever rigorous study you do to do that, but it seems like that is the case. And again, we don't really know where physicians have fit into these scenarios. I mentioned psychiatry is not mentioned, other than the plague outbreak in Syrah, where there's a report of physicians fleeing. You don't hear a lot about doctors in these different accounts. So that is a different question. And, some dysfunction, I think we have to accept. It's hard to find the sweet spot in emotional responses. We have to also, think about that there is, I think we might call benign versus malignant panic, right? So from past events, hoarding wine vinegar, that's pretty benign. Hoarding antibiotics, starting to head in the wrong direction. Absenteeism, and then ignoring the ill is malignant panic. And I guess the the modern day, the current versions of this, would be, I guess, the hoarding of toilet paper and Purell, or I think probably on the benign side. I don't think, for the most part, that I'm aware of, but I'm trying to keep my news watching to a modest amount about malignant panic. But there's certainly the potential there, and some of you may well know about that. But I think on the whole, we've not seen malignant panic, and there are, I think, lots of reasons for that. And I think just to kind of wrap up with this sort of a broad, sort of almost philosophical point, or the idea of the human response to pandemic, the behavioral response, kind of taps into a question about what our nature is, right? Are we civilized or rational at our heart, or are we uncivilized and impassioned, right? And this is, getting back to, always good to cite Freud in a mental health talk. He said that, that the task of civilization, right, the reason it exists is to defend us against our nature. Maybe, I think that there's room for debate there. I'd like to say that the reason for civilization is actually to express our nature, our good nature, and the inherent things the good that we do. And I think we're seeing that in the outpouring of what people are doing today and now at our hospital and our system. We saw it after 9/11, and I think we have. There will always be bad actors, but if I'm giving social commentary here, but I think we have reason to believe, to trust one another, that we're all going to do the right thing and maximize the chances that minimize the loss of life and the damage to our society. And that is the end of my talk. Thank you very much. Kent.
To show some perspective, thank you so much. I've muted myself. Thank you so much. And it was a great talk with a great overview. And it's very important to put things in perspective and see how we haven't changed that much over the last 500-600 years. But that we can learn, and that we can actually implement the things that we have learned, and hopefully we'll do better each time. And this is a time to show our good nature and not the bad parts. And I think a lot of people, and almost everyone is showing that, and standing up and helping out and taking their responsibility. So thank you so much for providing this perspective. So we have questions and answers. There's one that came up from Asher Simon. Greg, can you, I can read it, or can you read it?
I could read it.
Yeah, because otherwise the other people won't know what the question is. Thanks very much.
From Asher Simon, just a comment. As psychiatrists, we have a rather unique set of experiences. In our work, we almost always provide warmth and care from a social distance, without touching. I think we need to find a way to utilize, if not operationalize this, a la the quote from the rabbi. This being the case, on a practical level, how do you recommend counseling healthcare workers now, as many of us will be doing that for medical units in the near future? Well, yeah, firstly, Asher, I think, right, there's physical distance and there's emotional distance, or there's physical proximity and emotional proximity. And certainly we have a lot of practice, I think, demonstrating emotional proximity to our patients without touching them. You're absolutely right. So that's a really, really good point. Well, the question about how to counsel healthcare workers, I think that's a big question. I'm not sure if you have a particular aspect of that in mind, but I guess maybe you're speaking to the issue of distance. I think, I think with workers, you want to make sure that they feel that they've got the information. Some of it is very, very practical right now, I think. Do they feel that they're getting the information they need, the supervision that they need, the support that they need? Obviously, there are concerns about getting the supplies that they need. But I think, we're thinking in what we call sort of a psychological first aid framework here. So what are their basic needs, right? And so are they getting breaks? Are they eating? Are they sleeping? Things like that, the real basics. Are they connecting with their family? And then are they getting support? Those are the things I think that kind of need to be happening right now. Other things that are going to, of course, be coming up are helping them to, I think, acknowledge both their courage and their limitations. One of my, I think, there's a sense that understandably so, that our frontline workers are heroes right now, but being a hero is enormously burdensome. And I would guess, without doing a formal survey, that most of the folks in our ICUs and our EDs right now are not feeling heroic, and actually are feeling potentially disappointed in themselves that they can't do more. I bet there's also frustration that the system isn't doing more, but I think a lot of them are probably even questioning themselves, even while we on the outside looking in think that they are doing an amazing amount. So in any case, those are just some of my thoughts.
Thank you very much, Craig and Asher, for asking the question. There's a second question from Mercedes Burrage. Craig, maybe you can pick that one up.
Yes, so from Mercedes, the psychiatry education team have been brainstorming about launching several quality assessment projects centered on needs assessment among our patients, access to food, income, et cetera, and psychological impact. We would love your guidance on these. Yeah, I mean, I think that's, I think really getting at the basics for people right now is exactly where we should be targeting, where we're not, we're not at this point, and this is really, for the most part, focusing on, psychiatry as we normally do it, and psychotherapy. We might be talking about meds a little bit, but we're really not talking about psychiatric treatment, right? We're talking about, we say this, if you're going to be a mental health professional working in a disaster setting, you should think of yourself as a person first, a doctor or a healthcare professional second, and as a psychiatrist or mental health professional third. And if you think of those priorities, then I think you'll be heading in the right direction in terms of things we need to do for our patients and for our fellow healthcare workers.
All right, Greg, thanks very much. Yes. And then there is a question from an anonymous attendee, which is, I'm not sure that you can address that, but go ahead.
Are programs being created to be ready to hit the ground once this pandemic is over, hospital-wide? I assume you mean in terms of mental health. I'm not aware of what planning is going on at the hospital-wide level right now on that, but I would have to guess that's not where we're at. And I've actually been, in my mind, waiting for the government, SAMHSA in particular, to come out with RFAs, particularly around the Federal Stafford Act and the FEMA crisis counseling program. We may all, if you were here in New York, remember Project Liberty. It's a matter of time before those RFAs are going to come out, and I would think that we would be well positioned to respond to those, just like we did after 9/11 here. Right, our 9/11 program is still going, based on having grown out of some of those original grants, and I have good confidence that we'll be able to do the same here again.
Yeah. Okay, I think that, there are a few more questions. This is Mercedes thanking. There's a question from Cindy. You want to pick that one up?
Sure. One of the most disturbing issues that these frontline workers experience is a conflict between doing their jobs and risking the health of their families. For some, there are limited options to keeping distance within their homes. Once problem solving has occurred, any suggestions for how to deal with this? Yeah, I mean, that is a really, honestly, I'm not sure how to deal with that. I think something that I'm certainly trying to give some thought to. But I think though it certainly goes back to the question of, what is the Department of Health saying? What is employee health saying? What is your doctor saying? Listen to what their recommendations are, and don't feel like you have to kind of make it up yourself. I think now the problem there may be people don't know, but I would certainly still start with getting guidance from the Department of Health, et cetera. They're the people that are most up to speed on this. So that would be my answer.
Yeah. Okay, and then we're going to take Anita Ayer's question.
Sure. Can you speak to the impact of repeated exposure to multiple mass health crises? Are there any notable differences increased psychological resilience? Well, it's a very good question. I mean, I think it gets right probably to the question of just repeated trauma as well. And you know, I think with repeated trauma, whether it's a health crisis or otherwise at the mass level, a lot of it has to do with how the person is able to handle it. You know, one is, you know, we talk about having a past trauma being a risk factor for how you do in future traumas, but to some degree, it also depends on how you were able to handle it, what help you got. But you know, we know that there are lots of, you know, and there are also two schools of thoughts on this, right? One is that repeated traumas, you know, break you down. The other is that they build you up, right? That you get like psychological, you know, like scabs on your hands so that you're stronger for it. So, you know, the repetition can cut two ways, but generally we would think it kind of wears you down. And so, you know, there are certainly plenty of known, well-known resilience factors that certainly Dean Charney has written extensively about. But you know, I think some of the probably the most important ones that come to my mind, just in resilience factors, are also just general, or risk factors. The ways to help people best is social support is huge, whether it's at the professional level, in the professional setting, the job setting, or in their community or home. So social support is huge, and that's what they got at Liberia. I think also, you know, people that had problems in their lives before these events or in between these events, economic, social, marital, whatever, they're going to be at higher risk. And so, you know, I think getting back to dealing with the basics, you know, if we have a good social safety net and services in place to meet people's basic needs, they're going to be much better prepared to deal with repeated traumas. So those are just some of my thoughts.
Okay, Greg, thank you so much. I think we've come to the end of these grand rounds, which were a great success, obviously, because you are able to attract an enormous group of attendees. I think it was almost 500 at the peak, which is incredible. So you really served a very, very important need. This is recorded, so people can distribute it and other people can zoom in if they want to. So thank you so very much. Let's, you know, all stay safe, help each other, because exactly as you said, social support is the most important aspect for staying resilient and surviving all of this. Thank you very much again, and thank you all for attending this grand rounds.
Thank you, Dr. Khan. Thank you, everybody, for attending.